saying how glad we are that each of you is here. We have an exciting day planned for you. I'm going to share my screen so you can see what we have planned. Again, I'm Caroline Gooden with the Human Development Institute, and we're thrilled to have each of you here for our third, I believe, scope session. Our topic for today is NAS. This is a topic that lots of you have asked for, and our speaker is Diana Frankenburger. I'll tell you more about her shortly. Got a great day planned for you. These are all the topics that are coming up, and just so you know what's coming on which dates. Again, these slides are available for you on our resource site, so you can refer back to this. Brandon is going to shortly launch a poll so that we can see who's been attending which sessions. This is our agenda for today. We appreciate the feedback that you give us each week, and based on that, we've modified our agenda slightly. You all asked for a longer session with our expert speaker, and so we've done that. Diana will talk for about 35 minutes today. We'll then have a case presentation. We have two ladies who we really appreciate sent us a case presentation that you all received. That's Denise Jaeger and Wendy Kluender from Northern Kentucky. We're thrilled for that. They have an interesting case for us to discuss. We'll go into breakout sessions. Brandon is madly assigning you all to rooms even as we speak. The breakout sessions will be about 25 minutes this time. And then we'll come back as a large group at about 3:10, 3:15 at the latest to come back and talk about the strategies that we talked about in our small groups for this case. And then we will close by 3:30. Just to let you know that we have a couple of wonderful guests with us today. Canyon Hardesty is here with SCOPE. She's one of the SCOPE leaders. Canyon is Director of Community Education and Training for the Wyoming Institute for Disabilities, so we welcome her from Wyoming. She's also faculty at the University of Utah, and she directs a number of telehealth initiatives, so she has lots of experience in doing this kind of project. We also have Stephanie Weber with us today. She is also one of the SCOPE folks from the parent SCOPE organization. Stephanie hails from Cincinnati. She's helped us lots in planning our sessions. Stephanie's a clinical psychologist and is soon to have her master's in public health. Both Canyon and Stephanie are working on advanced degrees. I don't know how they do all that they do. Stephanie is the training director for the Cincinnati University Center of Excellence in Developmental Disabilities. So she does lots of training with students and practitioners across the state. She also works with the LEND, which is the Leadership, Education, in Neurodevelopmental and Related Disabilities. So she has, again, lots of great content knowledge for our topic, and we're excited to have them both. They're here as facilitators and co-facilitators with us today. So we're thrilled to have them. Welcome to both of you.
Caroline, is it okay if I go ahead and put this poll up?
Please do, Brandon. And you can just simply answer the poll, and then I'll keep talking while you're doing that. Just a couple reminders. As Christine said, please enter your name and agency, name yourself and your picture. Take care of your needs as we go through these topics. Be respectful of all of our sensitivities to some of these topics. Thank you for those that have submitted case studies, and please keep turning them in. We're glad to have them. We have lots of new resources posted for you on the resource site. I want to especially point you to a training initiative that is available for all of us in learning to be a peer support specialist. So check that out on the resource site. It's an abbreviated PSS flyer or something like that. We also have added lots of resources on fetal alcohol syndrome disorder per your request. So there's lots of resources there for you to see, as well as the resources that you all suggest in your breakout groups. We will be putting you into the breakout groups after Diana speaks. We know that sometimes when we put you into breakout groups that some people get thrown off of Zoom. We apologize that that happens with Zoom. When you come, if you get thrown off, just click the link and come back, and Brandon will reassign you to your group. Please be patient as we do, because it's a very time consuming to assign lots of people to breakout groups. So we appreciate your patience with that. And I'm going to now have the pleasure of introducing you to Diana Frankenburger. Diana has been a huge help in all of the components of this scope session. She's a speaker for us today. She's an expert consultant. She's guided our case studies. She's one of our participants, so she's all around scope person. Diana has her MSN in nursing. She's the prenatal education coordinator for UK Healthcare. She works for Pathways, which stands for, as you can see there, the Perinatal and Assessment and Treatment Home at UK. We've talked a bit about Pathways, and she'll tell you more about it. She's certified in inpatient obstetrics, childbirth education, and lactation, and she's a trained facilitator for centering pregnancy. So she has lots of important background. She's developed a lot of curriculum around NAS and related issues, so we are delighted to have her. Diana, I'm going to stop sharing and invite you to share your slides.
Can you see my slides?
Yes.
Perfect. Okay. Well, thank you, Caroline. That was awfully nice. My perspective on neonatal abstinence syndrome is perhaps a little different from some of you in these groups. I'm a nurse. I was a nurse at the bedside for 28 years, and then I started I became the childbirth education coordinator, became active in group centering prenatal care, and then that evolved thanks to Kristen Ashford, who was also a nurse leader in the College of Nursing, into doing group sessions for women with substance use disorder. So that's how I came to be involved in this in the first place, because it sometimes may seem odd that that's what I do. But I come at it from more of a nursing perspective. So just to let you know, that's kind of where I'm coming from today when you see some of the things that I'm going to present. My learning objectives for you today are to help you identify what neonatal abstinence syndrome is and to recognize the symptoms. I also hope that you'll understand potential short and long-term effects of NAS. And I hope that you'll be able to state initial non-pharmacological and pharmacological interventions that are used for the treatment of infants with NAS. And I hope you can also state some supportive potential measures for children and parents through early childhood. The opioid crisis has been upon us for some time. These figures are from 2017, when the United States Department of Health and Human Services decided that the opioid crisis was a public health emergency in America. 11.1 million Americans had misused prescription medications. There had been 47,872 deaths from unintentional overdoses, and 2.6 million people had developed an opioid use disorder. The use of heroin and pain medication had nearly doubled for women since 2009, and delivery records from hospitals indicate a quadrupling of opioid use disorder among moms since 1999. So these are all pretty frightening statistics. These have resulted in increased healthcare spending for prolonged hospitalizations to treat infants, and 50 to 80% of exposed infants will develop neonatal abstinence syndrome symptoms. These symptoms can begin in 24 to 48 hours. They usually generally always begin in 72 hours, and they can last for up to 60 days. This slide shows you a comparison of neonatal abstinence syndrome in the United States and in Kentucky. I'm not sure that you can see the dates on here. This is from 2018. And if you just looked at the graph itself, you might say that Kentucky seems to be kind of on a pattern with what we see in the United States. But if you look at the side, and I'm not sure how clear you can see that, in fact, neonatal abstinence syndrome in the United States is now up to a level of about between 6 and 7% of the rate per 1,000 newborns. In Kentucky, this rate, if you look at the side, is more like 23 per 1,000. So ours is much, much higher than the United States. This is from 2018. This is an NA rate per 1,000 live births in Kentucky from 2016. That Kentucky rate, as I said, was about 23.3. If you look in these different areas of the state, however, that rate varies dramatically. For instance, in the Purchase area, it's 3.1, but over in Kentucky River, it's like 69 out of every 1,000. So it's a huge difference. And Eastern Kentucky, as you can see from this slide, has a tremendous number of infants born with neonatal abstinence syndrome. So what is neonatal abstinence syndrome? It can be characterized as an infant's response to withdrawal of prescribed or unprescribed illicit medications and to substances they were exposed to in utero. It can also be potentiated by other medicines or substances such as caffeine or nicotine. It's often evaluated using several different scoring tools, but the most popular is the Finnegan Neonatal Abstinence Scoring Tool. And I'm going to show you a sample of that in just a minute. Scoring really involves evaluating how the baby is functioning in certain areas, and the score response is measured from normal to mild, moderate, or severe dysfunction. So that's how we evaluate babies for the severity of NAS or the development. This is a neonatal abstinence syndrome Finnegan scoring tool. Probably it's difficult, I'll bet, for you guys to see, but the areas that are evaluated really fall under three categories: central nervous system, autonomic system, and gastrointestinal system. They evaluate and assign a score based on baby's reaction. For instance, crying. If the baby cries, has a high-pitched cry, if they're able to self-soothe, how long does the baby sleep? If this baby sleeps less than an hour, there's a higher score than if the baby is able to sleep as many as 3 hours between feedings. Hypertonic reflexes, like a hypermoral reflex or startle reflex, is another one that you often see with these babies. And tremors. They can be tremors just of the arms, they can be arms and legs, and then they evaluate based on, do they have disturbed or undisturbed tremors? For instance, if you move the baby, they have the tremors, or just lying there on their own, they start to have tremors. They also will evaluate for excoriation, which is like a breakdown. Often this you'll see because they rub. They might rub their chin with their fist. They maybe rub their legs together to the point it causes skin breakdown. So that's excoriation, and that's what they would score for in that. They also score for seizures. I have not seen that very often, but that is also generalized convulsions. That's a potential side effect. And then other autonomic type system symptoms that we might see might include sweating. Babies don't generally sweat. They might run a fever. They might have frequent yawning or sneezing. They may have mottling of their skin. They might sound stuffy. They might have nasal flaring. And their respiratory rate may be higher than normal, usually higher than 60 respirations a minute. For GI symptoms, you often see excessive sucking. You might see poor feeding. They have disorganized feeding. They have difficulty with the suck, swallow, breathe routine. Often they'll have spitting up or throwing up, maybe even projectile vomiting. So they have lots of GI issues. And often they will have a lot of loose stools, even watery stools. We'll tell moms they may see a water mark in the diaper. If you were looking at just any infant and scoring them, frankly, they might score as high as a 6 if you were doing a Finnegan score on any infant. But these infants go move beyond that when they start to show withdrawal symptoms. And again, these are the symptoms that are affected. These are areas of short-term dysfunction. Central nervous system symptoms are a high-pitched cry, irritability, hypertone, hyperreflexia, and difficulty sleeping. And then GI problems, disorganized suck and swallow. They may also have weight loss, autonomic nervous system. They run fevers, they have stuffiness, they're sweaty, they sneeze, they have mottling, yawning, and difficulty, increased respirations. These symptoms are actually a result of changes in their neurotransmitters after opioids are out of their system. Opioids pass easily through the placenta to babies, and once the supply is no longer present, it results in increased production of various neurotransmitters and causes a cascade, which results in the things you see in those symptoms. For instance, after they stop having opioids in their system, their noradrenaline increases, and that's what causes that hyperthermia, hypertension, the tremors, the tachycardia. They have a decrease in dopamine in their system, which causes that hyperirritability and anxiety. And they have a decrease in serotonin, which causes them to be very difficult to get to sleep, have sleep fragmentation. And then acetylcholine increases, which causes them to have that diarrhea, the vomiting, that yawning, sneezing, and sweating. So these are all results of this, them no longer having an opioid supply in their system. That's just a sample of what NAS crying sounds like. Some of you have maybe heard that before. It is a distinctive cry. It's very high pitched. It's very frantic. And so it's a different cry than your usual newborn cry. So when do they determine it's necessary to begin treatment for NAS? Usually they start evaluating babies in the hospital when they start having symptoms. Usually those will appear within 72 hours of birth, and they begin scoring them every 3 to 4 hours. It depends upon, for instance, we score, I think, every 3 hours down here, but they score every 4 upstairs. So there's slight variances in when based upon your pediatrician. Scoring usually is evaluated, and if they start scoring greater than 8, if they score greater than 8 in 3 consecutive scorings, if they score an 8, but then their next score is a 4 or 5, that would be an indication for treatment. But if they score 3 8s in a row or 2 12s in a row, it indicates that their symptoms are escalating and they need treatment. And the length of stay in our area is for 5 days. Many hospitals I've talked to are adopting keeping them the 5 days, because often the symptoms don't start until about day 4. And so if they've sent mom home after a 2-day vaginal delivery, those symptoms may not even begin until she's already home with the baby. I think in the last session, it brought up a lot of good questions and a lot of good discussion about why do we treat women with opioid agonists if the result is going to be that babies have a reaction very similar to if they didn't have opioid, or if they didn't have those but just used opioids during their pregnancy. And so that is, of course, a good question. I went to the American College of Obstetricians and Gynecologists guide to look for why obstetricians choose to treat women with opioid agonists. And generally, their response to this epidemic has been that this helps prevent opioid withdrawal symptoms in moms who are struggling with this. It helps stabilize them. It gives them the ability to care for themselves and maybe for other children. It keeps them from using non-medical opioids instead. And they found it even improves adhering to prenatal care. It allows them to come in for appointments and get prenatal care, which decreases their risk of complications like intrauterine growth retardation, placental abruption, preterm labor, and even up to fetal death. So their reason is that they feel that the benefits outweigh the risks, and they believe that neonatal abstinence syndrome, while it is a very serious complication, can be treated with pharmacological and non-pharmacological interventions. They also believe that in participating in a program using opioid agonists helps decrease their participation in high-risk behaviors, and violence and STIs are also decreased when women are in treatment. And it decreases risk of relapse during pregnancy. We've had several women who wanted to wean off, frankly, before they had their babies. They said, I don't want my baby to have withdrawal symptoms, so I want to wean off before. And part of the problem with that is that sometimes then they wind up using again, and often that can be very, very dangerous for them because they don't have the tolerance to what they were using before, and it can result in very serious complications for themselves and the babies. And so we have found in our program as well that it's better for women to remain on the opioid agonist during their pregnancy, and then to make that decision later after their delivery and after they've stabilized, after postpartum recovery. So what about medically supervised withdrawal? Unfortunately, it's associated with much higher relapse rates, 59 to 90%. Often it results in poor pregnancy outcomes, accidental overdose, like I just mentioned, due to loss of tolerance, and higher obstetrical complications. Those complications can even result in fetal stress and up to death. And many times when women go through withdrawal of the medication, they stop coming to prenatal visits. They get lost to care. And so then we have complications resulting from that. The American College of Obstetrics and Gynecology also mentioned that they believe that prolonged inpatient care or intensive outpatient care is really necessary to help women successfully withdraw, and that that's often very difficult for them during pregnancy. However, our obstetricians and all of us must perform responsible care for these women. We need to encourage our OBs to be using screening tools to evaluate all patients for substance use disorder. There is not a great push for this. Asking the right questions so that you identify people who do need assistance. And obstetricians need to be educated on the risks and benefits of opioid agonist therapy during pregnancy, and they need to educate their patients on the risks and benefits. When we have women who are taking methadone, it's recommended that they remain on methadone during their pregnancy. That particular medicine is prescribed by an addiction medicine specialist, and it's given in a licensed outpatient setting with daily dosing and dispensing. So obstetricians do not prescribe methadone. That has to be through an outpatient specific that can do the dispensing. Sometimes also dosing for methadone may require some adjustment during pregnancy as they get further along. The other medication used for opioid agonist therapy is buprenorphine or buprenorphine with naloxone. Both of those can be prescribed by an OB care provider that's had specialized training. They receive an X license. There are several advantages to using one of these two. They can be self-administered. They can be prescribed in an office setting, which decreases stigma for the moms. Buprenorphine unfortunately has an increased street value, and so it has higher potential for diversion. So we started using several years ago buprenorphine with naloxone because it is considered safe in pregnancy because it's given sublingually. It's only dangerous to babies if it's injected. And so that's the reason that some providers won't give it during pregnancy, but in fact it's safe because it's administered sublingually. Naltrexone is not currently recommended in pregnancy. There have been very few studies because of ethical considerations, and the risk of overdose with relapse or treatment dropout can be really dangerous. So we don't recommend, ACOG does not recommend naltrexone during pregnancy. But whatever is chosen, the risks of neonatal abstinence syndrome symptoms are there with opioid agonist therapy, just like they are with other drugs, and they have to be communicated to the patient that this is going to be part of. I know several people in the session I was in
The only thing that he loved was his job.
said that they were not aware that their baby would have any withdrawal symptoms at all if they were on this medicine. And that's certainly not the case, and that has to be communicated. So the first line of treatment for NAS is non-pharmacological supports. These are supported by numerous organizations, including ACOG, the Academy of Breastfeeding Medicine, the American Academy of Pediatrics. All of them recommend the things you see listed here. Breastfeeding, when appropriate, has been found to decrease the symptoms of neonatal abstinence syndrome. Rooming in, whenever possible, keeping moms and babies together, has been found to decrease symptoms as well. And it also helps with maternal involvement. It helps increase bonding and attachment. Bonding and attachment is influenced by a lot of things. It can be influenced by mom's own personal experiences as a child or with her own mother, her feelings of guilt and remorse about what's happening with her baby. And so it's important to increase her involvement, to allow her to have time with her baby, to help her participate and care for her baby in order to build that bonding and build that attachment. It helps her through skin to skin to build bonding with her baby, through eye contact, reassuring holds and positioning, so teaching her things like infant massage and positioning, and just helping improve feelings of security for her with her baby will help her baby feel more secure even later in life. So these are some things that we also practice at Pathways and encourage. But skin to skin is something that probably you've all heard of, kangaroo care with babies. Something that you may or may not be as familiar with are the 5 S's, which are soothing techniques from Dr. Harvey Karp. He's a pediatrician in California. He recommends these for all babies, and we have found that they are very, very useful in babies with NAS. This video that I've attached here, we're not going to watch because it's 15 minutes long. So I've just attached it for you so you can look at the 5 S's and understand better how they work. I mentioned the clinic that I work at. It's called Pathways. Pathways started in 2014. I probably started with them in early 2015. Our goals at Pathways are to stabilize moms in their addiction, to provide them prenatal care and prenatal education, to provide group and individual therapy. We have therapists on staff for that, and we have social service support there in the clinic as well. We have 2 peer supports, Marie Weiss and Bethany Wilson, and they are wonderful to have with us. We do NAS symptom reduction training. It's one of the sessions that we want all of our women to have. We encourage all of our women to breastfeed, and we also provide smoking cessation or reduction advice and training. When we started having prenatal group sessions back then, they began to track women and how many groups they had attended, and they found that for every prenatal session where we covered often ways to care for your baby, ways to comfort your baby, all of the things I mentioned, breastfeeding, smoking cessation, all of those things. For every session attended, our women were 13 to 18% less likely to have a positive screen for illicit drugs when she came into the hospital. So when we saw that, we thought, wow, we better track who's attending what so we can make sure they're getting all this information before they come to the hospital. So we began tracking exactly what women had attended, and we sought out incentives for them for completing attendance in the educational sessions. And so now our women actually are much more eager to complete their education because we've provided them with incentives such as car seats and pack and plays and things that they can use with their babies later on. We also found that the more we could involve hospital staff in caring for women at our facility, the more comfortable our women were when they came in to the hospital. and they saw people that they recognized and knew, and so they felt better supported. So we have a neonatologist who came and talked with our women, explained to them what to expect. We have physical therapists who come in and actually go over infant massage with them prior to their hospitalization. We have different RNs for the mother-baby unit. We have a special unit for babies who are going through evaluation for withdrawal. And we have RNs from there come and talk about what to expect while you're there. We have an IBCLC who's come out and talked with them about breastfeeding, giving them great tips for that. And we've even had music therapists come out and talk about how to use music to help comfort your babies. All of these interventions help empower women to have tools to help their babies through this withdrawal time. And it gives them knowledge which decreases their fear and anxiety about what they can do to help. I'll just give you just a quick example. I had a couple of women who were in the hospital at the same time. One had been in our Pathways program and had had a lot of the trainings. And one I saw in another clinic. She was on methadone. She was not part of our clinic. She went elsewhere, but she did come for her OB care, and so I'd seen her obstetrically. They both delivered, were in the hospital, and when I went in to see the woman that had not had any supports, her baby was crying and frantic, and she was frantic, and she didn't know what to do, and she felt just totally overwhelmed. She was crying, baby was crying. So we went through some different techniques. I showed her some different things to try, and we were able to give her some tools to use. And then I went in the room down the hallway, and the woman who had had some of our prenatal sessions, she had a list. And she said, okay, I'm doing this now because he scored this the last time, and I think this is going to help. And she was keeping track of what the score was and what she could do for that. And that was I think one of the biggest impacts for me, that it does work. If you give them tools they feel like they can use, it does help them feel like they can care for their infants. This is just a sample of one of the things we go over. This is one that we repeat several times so that all of our women get it. We have a session where we explain those symptoms, and often they're very familiar with what the symptoms of withdrawal look like. They've been through withdrawal themselves, and so many of those symptoms are not really a surprise to them. But so then we usually have a couple of white sheets up, and we have them on one list the symptoms after we go over them. What are you going to see? And then decided, okay, what can you do for that? I'm kind of a nuts and bolts person. So if you see this, then what should you try? And it makes them start to think about themselves in that situation and how they could handle it. And we also send them with this to the hospital so that they can have those things. They don't have to remember them all, but you know, having visited something before in your head at least gives you that idea of what you can do for it. We do encourage our women to breastfeed. The American Breastfeeding Academy of Breastfeeding Medicine supports that. Women who have appropriate drug screens should be encouraged to breastfeed. Breastfeeding does decrease NAS symptoms. It's not that they decrease them because it gives them some of the drug that mom is on. They found it probably has more to do, because it's such a minute amount in breast milk. It has more to do with the holding, the touching, the eye contact. It's all of that skin to skin and that contact that breastfeeding provides. Breastfed infants are less likely to require medication for withdrawal. However, women who have relapsed in 30 days prior to delivery, they don't recommend breastfeeding. And if they've relapsed in the last 30 to 90 days, they should really be evaluated on a case-by-case issue. We've also found that breastfeeding actually reinforces sobriety with their because they want to stay clean to breastfeed their babies. And it increases their self-esteem. It makes them feel like they're doing something. They know they're doing something special for their babies. And to be honest, breast milk is much easier digested by these babies. They have fewer GI upsets. If we can have moms breastfeed, we know that we'll have fewer GI upsets for these babies.
Anna, we had one question you might want to answer. Do you have resources for music therapy? And this is also your 5-minute warning.
Oh gosh, okay.
Okay.
I certainly could put you in contact with our musical therapist, whoever that is. Yes, we do have a music therapist here at UK on staff, and I could certainly link you with them.
And we'll add that to the feedback resource sheet, you all, that we do after this case study. Thank you.
Okay. So hospitals, what should they be doing? Staff really need to be trained in trauma-informed care. I think that's one thing that's lacking for caring for this population in general. And nurses need to receive ongoing training about evaluating with Finnegan scoring. And nurses need to be willing to teach these moms some of these non-pharmacological soothing techniques about skin to skin, white noise, all of those things. And they should be encouraged to breastfeed. We have found that it's really better not to use alcohol wipes because we talked about that breakdown of the GI system. And so 4x4s with sterile water have been found to be a lot better for babies. And when you're talking about using breastfeeding and skin to skin and all those things, it's very, very important to remember to encourage safe sleep practices. It's very easy, as any of you have had children know, you're holding a sweet, cuddly baby next to you to fall asleep while you're holding them. And so we have to really work at that. Having a dedicated unit for these moms and babies has been a big boost to our women being able to care for them. And care by parent has been found to be, with rooming in, one of the best therapies, the first line of therapy by the American Academy of Pediatrics, and it increases breastfeeding rates and decreases the need for medication. If medication is needed, the first and go-to is usually morphine for babies. If they are placed on morphine, their average length of stay is about 21 days. For some babies, if they've been on methadone, they might use methadone. We don't at our hospital, but there are some others out there that do, and then it's about 14 to 21 days. Buprenorphine has a length of stay that's the shortest. Generally, it's 9 to 15 days. We did used to use buprenorphine in our hospital, and we found about an 8 or 9 day stay was all they required. Clonidine is more of an adjunctive. It assists in decreasing the length of stay because it helps decrease symptoms. We're doing a study here where clonidine and morphine are being compared as to first lines of treatment, but that's an ongoing study. And then phenobarb is used as an adjunct as well to decrease length of stay, and it's often used if they also had benzos. Treatment is considered adequate for these babies if they are able to sleep and feed in cycles and they're making appropriate weight gain. Like prematurity, issues with NAS don't go away once they outgrow their babyhood. But there are more studies that are needed on long-term effects. Unfortunately, children with a history of NAS are more likely to die than other children through adolescence. This risk can be linked to lots of other factors, and you have to think about that. They include things like lifestyle, economics, genetics, social issues. All of those things have to be considered when you look at information about NAS and long-term effects on babies. What studies have shown is that they are more likely to die between 28 days of life and 1 year, with the most common cause of death being sudden infant death syndrome. In fact, infants who have suffered from NAS are 10 times more likely to die from NAS than other children. And a lot of opioid exposed children, about 25%, don't receive the needed health care that they should in their first 2 years of life, which results in hospitalizations for problems that have just been left untreated and normally would not require hospitalization. If these women can also be provided with care after their discharge, like home-based visitation programs such as HANDS here in Kentucky, Beyond Birth, which is another one I will talk about, New Vista, which is a program that I think some of you are a part of that can provide first steps for children up to age 3, and then access for ages 3 and up. Those are great programs to continue assistance, and Voices of Hope is provides a community for support like throughout the rest of their lives. So all of these aids are really important. Beyond Birth, which is here in Lexington, continues support for patients from our Pathways program and others here in our community. They provide parenting classes that are approved through DCBS. They have attorney services available. They do job prep services, GED assistance, and they also have group and individual therapy sessions. They too use peer supports, and they can provide medically assisted treatment.
So Diana, we've got a question from Jody Gray. I think she might want to unmute and ask a question, if you're okay with that.
Sure.
Jody, if you're there, you can unmute and ask your question, or you can put it in the chat.
I am, yeah, I am now. Yes, Diana, were you saying that the babies who have NAS are more likely to die from SIDS? Is that what you were saying?
Yes.
Okay, because I think you said they were more likely to die from NAS, but you were referring to
sorry.
yeah.
Okay. If I said that, yeah,
Okay.
I just said that incorrectly. Yes. Yes. Infants.
Yeah, just clarifying.
Yeah.
All right, thank you.
Thank you.
Thanks, Jody.
Okay. So it does take a village. We do need a multi-system approach to help these women while they're pregnant and afterwards. And we need to make sure that they're aware of non-pharmacological therapies. We need to help them feel supported and continue assessing babies and their attachment through the first year. And home-based programs are showing lots and lots of promise in helping improve outcomes for these children long-term. I'll bet my 5 minutes is up.
It is. That was wonderful, Diana, and we'll circle back after our case study when we come back to talk at the end. It was wonderful information. We do have some great questions, and we'll put some resources together based on things that were shared. If you want to stop screening, I will share my screen, and we'll have Denise and Wendy, if you're here. I know you are here. If you want to talk to us about your case presentation. So Denise and Wendy, if you want to unmute, let me know when you're ready and I'll start advancing slides.
And this is Denise Jager. I'm ready to go.
Great.
I'm Wendy Klunder.
Hi.
So, Wendy and I, we work for First Steps, and then we also work for Ohio Early Intervention. So this is one of our Ohio families. This kiddo, going by Lucas, he's one that I've worked with the family for a while. I worked with the older sibling that had an NAS diagnosis. And then this family also adopted Lucas as well. So he was exposed to pretty much anything mom could get her hands on. So there's the list of those there. Dad was also a polysubstance abuser, and he actually OD'd a few days after Lucas was born. He spent a couple weeks, his first 2 weeks in the NICU, he was in a UC study, an adoptive family. They didn't have any rights at that point, so they had no choice in withdrawing him from this study or not. First couple weeks, they did not do anything. They wanted to see, I guess, what the effects were for a child that received no treatment. After those 2 weeks, they decided to pull him from the study and start methadone because he was reacting so poorly. He was having so many tremors and just having a lot of distress. So when we started with him in EI, his original diagnoses were NAS and torticollis. Things that I was seeing with adoptive parents was still having those tremors for the first month after he came home, excessive startle reflex, still trying to figure out with biomom any other substances that might have been used. but we just kind of worked on different sensory inputs and things that would be helpful for him. One part that was hard was that UC was recommending something different from what I had seen. They were doing kind of the opposite for SI. They were overloading him with sensory input. And they were saying that that's what the current research was to help a child. We tried to go along with that for a little while, but that did not seem to be effective. So we went back to, slowly kind of desensitizing him to that input. So right now he's 19 months. Wendy, if you want to talk a little bit about the gross motor piece.
Yeah, I started seeing him because he was late meeting his gross motor milestones. Right now he does walk, and he falls frequently. He trips over toys that are in his path. He was running into walls and things, but that's a little bit better. But that's been kind of a frustration for us because we've had trouble sort of pinpointing the reason, whether it's vision or balance or something else.
And then one big thing that we see with him is a lot of that sensory seeking kind of things. He is one that he doesn't want to just like push toys around. He wants to push heavy furniture. So he wants to push the couch around, the dining room chairs, things like that. We see a lot of the hitting, the throwing, the rocking. He doesn't like pulling objects, but he'll push everything. We were seeing lots of biting and pulling hair. Some other things going on with him is language is definitely delayed. We get some consistent signs from him, and he's just started kind of shaking head yes and no. And then his receptive language seems to be pretty good. Like he can follow a lot of simple directions, but no words so far. During our session last week, Mom mentioned that he's still in the 1 percentile for height, and then 60% for weight. They're looking at some different genetics things, maybe Noonan and some endocrine disorders. We suggested the ophthalmologist just because of the vision issues to rule that out. Wendy, do you want to go into a little bit more detail about that?
Yeah, I don't think they found any sort of refractory problem, but we are thinking that rather than an actual vision problem, he probably has problems processing what he sees. Just because he certainly does, he can see things and pick them up and, look at people who are talking, but it's like when he's moving around, he just doesn't seem to be able to kind of integrate all that stuff. And actually had a recent situation where he was at his grandmother's house where it was visually really overstimulating, and his issues were even much worse as far as being able to be calm and walk around and move in his environment.
So this next part, this is, Mom knew we were presenting today, and these are some of the things that she would really like to be able to see. Just trying to find more effective ways to kind of meet his sensory needs, because he seems to be very particular about that. She would definitely like to see his speech improve, and then walking without falling. Some of the barriers is some of the sensory piece there, trying to figure out how best to meet his needs, and kind of what Wendy alluded to with the vision, vestibular, and motor kind of skills. And then just the strengths. He has a great adoptive family. They are very involved with the coaching model and are great at following through with recommendations. And then, I had previously worked with their older adoptive brother who also had NAS, and he's made really good progress. So I think like another part in here is also for him was different for me, was that we saw a lot of the NAS things in the beginning, the regulation issues, and then they got better for a few months. And then all of a sudden it's like somebody hit the reset button, and we kind of reverted back to the way he was previously. So not for sure. I hadn't had that experience with other NAS kiddos, so don't know about that. So we've been trying different things with him. We just recently started doing the compression vest. We need to get a different model that can, it just wasn't the right size. So looking at some weighted things for him. We did a lot of the infant massage in the beginning, kind of going along with what Diana had mentioned. We had talked about some of like the happiest toddler on the block kind of strategies, thinking about that. We've done brushing. Brushing worked pretty well. Super sensitive to it on his hands and his feet. They're still continuing brushing and joint compressions. We've kind of incorporated some balance, so some vestibular and proprioceptive strategies as well in there. He did like swinging a lot when he was an infant, and he likes doing some rocking kind of things. So kind of exploring more of like rocking chairs and things where he can be independent with meeting his sensory needs. And then mom's done a great job of kind of recognizing the visual stimulation that might be going on. So she just recently created a new room for him that he can go to that has, you know, very minimal sensory stimulation.
That's fabulous. Thank you, ladies. And I'm just going to show everyone the last slide that we have. This is some additional resources, and it's from Diana. It really supports what Wendy and Denise have said about this student, this child. So that's additional information for you that's in the slides. And I really appreciate both of you bringing this case before us. I think we'll get some great discussion. I hope we get some great feedback for you all and for the mom as well. So we're getting ready to put you all into your breakout groups. Again, if you have trouble, if you get bounced off of Zoom, just please come back into the main room and Brandon will reassign you. Brandon, we're going to go for about, we'll go till about no later than 3:15. We'll bring everybody back to share strategies. While you're talking in your breakout groups, if you'll list some family strengths for the family and the child, talk about some strategies based on your experience, what you think might help this little guy, and any resources that you have that would perhaps be helpful. We've shared some resources already, for instance, the music therapy and the 5 S's resources. So if you have others, please feel free to share them. And we will bring you all back no later than 3:15. Denise,
Caroline, can I interrupt real quick, 1 second?
Sure.
For the group, did anyone have any questions that they wanted to ask Denise or Wendy before we broke into our groups about this particular case?
I have a question. Oh, go ahead, Molly. I'll go second.
I had actually just texted Christine about that. Does he, or Denise, sorry, does he sleep well?
We've kind of had an up and down cycle with that. So in the beginning, he was only sleeping 15 minutes at a time, and that lasted probably a couple months. And then it got better, and then it got worse, and it was bad again for probably 4 to 5 months. And then it just recently started getting better again the last couple months.
When you saw that backward slide in his development, was that correlating to his lack of sleep?
No. Like, are you talking about in regards to like the balance and speech, those kind of things?
You said he was doing really well, and then he took kind of a backward slide, like he reset.
Yeah, it was in regards to like his sensory processing and regulation.
But that didn't correlate with the sleep?
No.
Stephanie, you had a question?
Yeah, my question was, I'm a little bit fuzzy, and this is for me because I'm in Cincinnati, about the being treated at UC, and there was a research study or something. So is he not being followed by any NICU or NAS follow-up clinics currently?
They did switch. So once adoptive family got the rights to make his medical decisions, they did. They switched him to Children's with the high-risk clinic.
Okay, great. So he's connected with Kathy and all of those folks there. Awesome. Because I agree. I think that, like you mentioned, the overload of sensory strategies, from what I've learned from my OT friends, is that these kids tend to be sensory cravers, and it's almost like they're addicted to that sensory input, just like their brains were born addicted to the drugs. And so we have to put some sort of boundaries around it, and that's unfortunate. So I might ask you offline, like who at UC, because we need to do some education.
Okay. All right.
So
I also wanted to ask about the torticollis. How much is that affecting things at this point?
I would say he doesn't really have any signs of it at this point. He does have a few things that sort of seem a little asymmetrical, but nothing noticeable. And I think we didn't mention this earlier. There was a time when they were telling the parents he might have CP. And we never saw that. We really didn't think so. And weren't they throwing around autism also?
Yeah, and this was one of the UC nurses. They were very quickly telling him the mom that they felt like it was autism, and we weren't seeing, I mean, besides the head lag still happening, we weren't seeing any other red flags that were making us think autism. So we just didn't, mom and them just didn't have a great experience with UC, and I feel like that really was a huge barrier in the beginning because they weren't getting the support that they needed, and feel like it's going better now.
So I will just suggest, as we get ready to put you all into breakout groups, these are great questions, and feel free to add more questions to the chat or put them on your notes as you take them in breakouts. I would suggest that you either take a picture of the questions that you'll discuss now or jot them down. Again, we're going to talk about strengths. We're going to talk about some strategies and potential resources. So you can photograph this slide if you wish, or jot those down. And again, we are going to move you into breakout groups. Please be patient and have wonderful discussion, and we'll see you back here at 3:15. All right, Brandon, I'm going to try sharing my screen. Seems like people are coming back in. All right. Give me a thumbs up if you can see the PowerPoint. Okay. So let's look at some of the, and in fact, I think we don't even need the screens. I'm just going to do this so we can see our faces. Any group that wants to go first in sharing some of the strengths, needs, or especially strategies that you shared? I'll look for a volunteer first.
I will be happy to volunteer first.
Thank you. Go, Leslie.
Okay. So family strengths and child strengths. Well, the fact that the family has already adopted his older sibling with NAS, so they've got some knowledge. And then we talked a lot about some of the adaptations that the family's made for him with his vision concerns, making him an area that's quieter, less visually cluttered, a space where he can go to calm down. The fact that they're recognizing that that helps him is huge. Let's see. And then what was the next question? Resources and
strategies.
Okay, for strategies, we talked about making sure that the family has strategies to help with his aggressive behavior, giving them some strategies they can use at home, which could include socialization with other peers so that he's learning how to communicate effectively before he enters preschool. That could be driving some of his frustration and his aggressive behaviors. Also, some support group for the parents, if we could find some of those. I think Stephanie mentioned Northern Kentucky University has a support group for families. And there's some online support groups that might be great for them to speak with other families that are going through the same thing. And then some other resources online. There's a lot of vision resources for families. There's Perkins School for the Blind has an e-learning to go podcast, which has a ton of information on different topics and how to adapt environments, working with daily routines, just lots of good information on there. And then Little Bear Seas is a great one. CBI Connect is another good one. So lots of good online resources for families that might have a hard time getting, resources or getting to Cincinnati or just depending on where they live, that kind of thing. So
fabulous. And I would ask, when your facilitator takes notes for each group, please send us all those great resources, because we will compile them and we will send them to Denise and Wendy. Those are great suggestions. Another group want to volunteer to share?
I'm happy to go.
Thank you.
Sure. I won't mention the same things that Leslie did, just to say some different things. We talked about strengths, that the family seems to have a strong rapport with the providers who they're already working with. So looks like they're already connected with community resources such as First Steps and seem to have a strong rapport with those providers. So that's helpful. Some different strategies other than the vision things mentioned, talking about sensory play and things that through play the child could calm and regulate and start to learn how to do that on his own. Teaching him some sign language to address the expressive communication delays that are noticed. There was a suggestion to create some little small nook kind of spaces, since the families noticed that that seems to be calming to the child, maybe a little tent of some sort, and so he can be in there with someone else or alone to calm. And then exploring the bedtime routine. We all were kind of blown away with the waking up every 15 minutes. And so looking at that bedtime routine, could something be adapted, changed? Again, looking at kind of regulation issues. And then with resources, we also mentioned the support group, but thinking about PCIT to maybe address more long-term, thinking about attachment, thinking about guidance. And a kind of a global issue can't be addressed with this one case. Would be nice to have more access to the bio parents' health and social histories to realize how much of this might be a genetic component.
Thank you very much, Elizabeth. Those are great resources.
You're
Thank
welcome.
you. Someone else want to share? Amanda, you're unmuted. Would you like to share? Thank you.
I'll share. So some of the other strengths we had talked about, other than what was already mentioned, was the mom was truly an advocate for the child, or both children, and that even having the sibling in the home was definitely a support. Some of the resources that we felt were being very important would be the Kentucky Department for the Blind, and they would assist with the child all the way through school, even through college, and give many resources in the home, as well as collaborating with their school systems. And then Kinder Music is an awesome program where the parent and child would interact with one another. And conscious discipline. Conscious discipline would allow for that present touch and in a fun manner, and helping with behaviors, also sensory, as well as relationship building and bonding. And they have what's called I Love You rituals in that program, as well as many songs that teaches them how to stop, take a deep breath, and relax, as well as crossing over their midpoint. And then another resource that may not be helpful for this family necessarily with the adoptive family, but for other families who the biological parents still have the child, and even during pregnancy, is a home-based program with Early Head Start. And there are home-based programs in 12 counties for sure with Audubon Area Community Services. And they help all the way through pregnancy, and then even once the baby's born until they turn 3. So that would be an amazing program for families to take advantage of.
Thank you, Amanda. Wonderful. Do we have another volunteer to share?
I will go ahead and share for our group.
Thanks, Marie.
We got to talk about a lot, honestly. A lot of it has already been mentioned, of course. We also liked how the family made the special accommodations for his sensory. Our group did talk some about the torticollis. Maybe we could see if there had been any research done, whether it's related to NAS or not. We had some people say they see that quite a lot. We had discussed in length a lot about the START teams, whether the availability of it, see if that could be a resource for the adoptive parents.
Marie, do you want to share the START teams?
I can't say the acronym, but I can tell you what they do and what they're for. They are for ultimate reunification for the biological parent and the child. But in an adoptive case like this, they would give them the support of a therapist, OT, PT, all of any kind of necessary, link them to the resources that they may need, and they assign them like a whole team of people. So they kind of do wraparound services for parents. They just have very limited ability or availability here in the state. They're only here in a few counties. They're not in every county. So it's touch and go where you can and can't get them. So our group talked about that a lot. We also brought up CASA, which is kind of a court-appointed system that helps adoptive families and foster families in the state. Helps link them up to other resources, of course. First steps. We also talked about, Wendy was able to say that maybe hopefully they can get an MRI done and look into other medical things that they can rule out causes of what some of his behaviors are, right? And hopefully maybe it's not just NOS, it could be the reason for this medical diagnosis or whatever the case may be. Yeah, we came up with a lot.
Wonderful. And I would just remind you all, if you're not speaking, to mute. There's several people that are still unmuted. And we have time for another person who would like to share.
Great. Could I share for our group? This is Kate.
Please do.
Okay, great. Our group had a lot of great things to say. I'm going to focus on a few areas to explore, a couple of resources, and then just a few strategies. Areas to explore include the potential for neurological issues. Perhaps there's a seizure component, so having them seen by a neurologist, possibly for an EEG. Also that allergies, have allergies been explored due to the effect on the vestibular system? And has there been consideration for reflex integration, and perhaps looking at that as an due to the startle reflex that he is experiencing? A couple of resources include a CD called Calming Rhythms by Jeff Strong, and there was a note made that the music seems to be the opposite of what you would expect for calming, but it works well to help reset the brain, and that there's a very specific, almost like curriculum that goes along with that will help with parent education. And then a book called How Does Your Engine Run as a resource for the parents as well. And then a couple of strategies include logging what the child finds calming, so that you could start kind of a sensory diet for the child to help at different times of day working on certain things. That swinging on the belly could be very helpful for the visual processing and providing a different type of stimulation. And then lastly, considering needs for oral input. And so perhaps a sensory diet, or we have one of our team members will share what they called their oral motor grocery list. And so there may be some resources there that we can include.
Great. Thank you, Kate. And Christine's added a great helpful hint in the chat. I want to give Canyon's group a chance to share if you want. Any additional strengths, strategies, thoughts?
That group 3, is that us? I know we haven't went yet, I don't think. So I'm just going to bring us on home, I think. And I echo, we talked a lot about what the other folks have been saying. So just some of those strengths is, you know, the adopted family has experience with children already with NAS, and has a little bit of understanding on what to expect, and that Big Brother is a good influence and a good mentor for Lucas, and that he's got a good support system in place, and that the OT and the PT will work well together. So one of the things I've really enjoyed listening to all those strategies, because there's so many of them, and someone in our group that talked about the ophthalmologist. And so, you know, instead of going to an ophthalmologist to get instead to get a functional vision assessment to kind of figure out what's going on in that light as well, just to get a little bit of a deeper understanding of what might be going on. And like you all, we talked a lot about the peer support. You know, we know that foster mom or mom's busy. And so just really having and finding some of those informal virtual supports that are available where you can, you know, maybe hop on at night, you know, when you get a little bit of time for yourself. So the resources, we echoed a lot of what you said, and then also to find some of those sites, those virtual sites to give the parents support. So
fabulous. Thank you, Joy.
Thank you.
And I thank you all for a really rich discussion today. Excellent discussion, excellent information from Diana. And I'm going to turn it over to Emily to close us out. We will see you all in 2 weeks on October 6th.
I will unmute myself. So again, thank you all so much for coming today. We really appreciate your participation and contributions. I will be sending the evaluation email within the next hour after we conclude here. Again, if you don't see it in your inbox, please check your junk mail. And if you don't see it at all, please contact me and I'll just send you the link. We do really appreciate your feedback. So if you have, I know there's a couple places to type in answers, and we read all of those and we try to adjust every week based on your feedback. And so as much feedback as you're willing to give us, we are very grateful for. So another thought that we had was starting a Slack workspace, if anybody's familiar with that, where we could kind of continue the conversation throughout the week. So maybe if you're interested in that, we already have one set up, and I'll send out the link with our next round, or maybe I'll send it out earlier so that we can get started on that. But that'll be a way to kind of, if something comes to you later, you could go to Slack and everybody will see it. It's more of a discussion board if you haven't used it. But thank you again so much. We really appreciate you all being here. So,
thank you all.
Yeah.
We're done. We'll see you in 2 weeks. Thanks so much, everybody.
Thank you. Bye.
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 Bye, Barb.